안녕하세요. Welcome to another lecture in the Counseling 5480 Diagnosis and Treatment Planning course. In this lecture, we're going to cover obsessive, compulsive, and related disorders. Now, let's get it started. In this chapter, there are 9 different obsessive, compulsive, and related disorders. And in this video, we're only going to focus on the top 5 disorders. So the 5 disorders listed in this chapter all featured in some type of either obsession and or compulsion. People with OCD struggle with general intrusive thoughts and compulsive behaviors. And body dysmorphic disorder is characterized with the obsession surround the imperfections in someone's physical appearance. And sometimes, actually lots of times, those imperfections can only be identified by oneself. Like to other people, there's nothing wrong, but to the client, that is such a big deal. People with hoarding disorder are so obsessed with their possessions and they just can't let them go. And a lot of them are also compulsively keep collecting their possessions, regardless of their values. Trichotillomania is the compulsive behavior of pulling one's hair. Excoriation disorder is the compulsive behavior of picking one's skin. I am sure you hear about OCD all the time. So when you hear this term OCD, what does it come up to you? Are you thinking about cleaning to a perfection level or obsessed with organizing everything, rank everything? At the bottom of this slide, there is a YouTube link that I would highly recommend you to watch it. It basically gives you an overview of OCD and kind of corrects you for some misconceptions you may or may not have. So, what's the difference between obsessions and compulsion? Generally, we use obsessions to describe recurrent and persistent thoughts, urges, or images. So it's more of a cognitive level speaking. Compulsions, on the other hand, usually refer to repetitive behaviors or mental acts. So it's on a behavioral level. What are some of the example obsessive thoughts? People could be afraid of being contaminated by germs or dirt, or being contaminated by others. They are worried about their safety, or maybe the fear of causing harm to either themselves or others. Some obsessions could be intrusive, sexually or violent thoughts and images, excessive focus on religious or moral ideas, or having this idea of that everything must line up in a perfect way. And some other ones are also including like superstitions, and always pay attention to if something needs to be considered as either lucky or unlucky. And some of examples of compulsive behaviors include that they double checking everything, double check their logs, or maybe even triple checking, check the switches, check all the appliances in the house, repeatedly checking in on the ones they care to make sure they're safe, constantly call the partner or call the babysitter to make sure that the partner is okay and the baby is okay. And something that's often featured in the movie is that people are constantly counting, tapping, they have to repeat certain words a number of times, or doing some other meaningless things just to calm themselves down. And they may spend lots of time washing and cleaning, ordering or arranging things in a perfect way, or praying constantly, or they feel like they are compelled to engage in certain rituals because of some religious fear or superstitious fear. So here's how it works. A person will have an obsessive thought. such as they have to always wash hand every time they shake hands with someone. And then that obsession will cause a strong anxiety or fear. They may think if they don't wash their hands, they may catch germs. And then that feeling is so uncomfortable to the point where they just have to do something. And that leads to compulsive behavior. So the person eventually goes to the bathroom and wash the hand. And then the person experiences such a huge relief after that behavior. Then maybe another person come and shake hands with the person, and then they repeat the process from the beginning. OCD has 4 criteria. Let's look at each of them. Criterion A requires the individual have either obsessions, compulsions, or both. So obsessions are defined by recurrent, persistent thoughts, urges, or images. Individuals usually spend lots of time trying to ignore or suppress these thoughts by doing things such as performing compulsion. Compulsions are repetitive behaviors that are aimed at preventing or reducing the anxiety or distress usually caused by the obsessions. Criterion B specified that the symptoms need to cause significant distress in and the impairment in the client's daily life. Specifically, DSM-5 provided a way to measure the significant distress as that the individual needs to spend at least more than 1 hour per day on their obsessions or compulsions. Similar to other disorders, we want to make sure these symptoms are not due to substance use or medical condition and is not better explained by any other mental disorders that may share similar symptoms with OCD. You have 4 specifiers to use. If the person believes that most of the obsessions or compulsions are not true or they don't make sense, then you can use the specifier of individual with good or fair insight. If they believe that most of these things make sense to them, you can say that they have poor insight. If they believe it's 100% true, then you can note that they have absent insight or they don't have any insight, and they may even have some delusional beliefs. If the individual has a current or past history of a tic disorder, you can also add the tic-related specifier. At the bottom left, you can see an example of an OCD diagnosis. F42, obsessive compulsive disorder with poor insight. All right, now it's our good old myth or fact time. Males are often diagnosed earlier than females. Is that a myth or fact? This is a fact. About 25% of males with OCD actually have symptoms even before age of 10. The next one, most clients have either obsessions or compulsions, but not both. What do you think? This is a myth. So yes, most clients do have both obsessions and compulsions because remember, compulsions are usually used to um, decrease the anxiety caused by the obsessive thoughts. Most clients fail to recognize their OCD beliefs are irrational. Is that a myth or a fact? This is a myth. Actually, most clients do recognize that their obsessions and compulsions are irrational. Only about 10 to 25% of them don't recognize that. And these people usually have a poorer prognosis, meaning that they recover slower than their peers who have better insight. OCD can be chronic and debilitating. What do you think? Yes, this is definitely a fact. 15% of people who suffer from OCD actually just are so painful that they attempt to suicide. So again, suicide screening and prevention is super important. So the last one, some with OCD may have a rigid conscience, a strong sense of guilt and remorse, a high need for control, self-doubt, and perfectionistic qualities. What do you think? Yes, this is so detailed, so it is a fact. As a matter of fact, these are some of the characteristics or temperament factors for people who develop OCD. If you're curious to know what the world look like in someone who has OCD, then you can watch the YouTube video A Day in Life of OCD using the link at the bottom on the slide. I'd like to introduce Janelle Jones to you as she is experiencing OCD in this case. I'm going to read it, and I want you to kind of identify the obsessions and compulsions, and maybe also to evaluate which specifiers you would like to use on her. Janelle presented to session as cautious and shy. She was in the 9th grade and talked about wanting to fit in with her friends. She mentioned enjoying sleepovers, listening to music, and going out for ice cream. As Janelle began to share about her likes and dislikes, she shared about being afraid of losing her mom. I'm afraid she's going to die, and I'm never going to see her again. Janelle began discussing how this thought became so scary that she could not stop other thoughts from entering her head. Janelle indicated that although she loved music, she could not listen to music at volume of 7 or 13 as these were bad numbers. When asked to elaborate on what she meant by bad numbers, Janelle went on to say that she believed that if music were to be played at either of those volume numbers, her mom might die. Janelle continued by sharing about having a difficult time crossing entryways. She preferred to take large steps when entering rooms to avoid stepping on the crack and space between the door and the next room. Janelle also indicated that she had to turn on the lights 3 times when entering rooms as at her house, or the fear and anxiety of her mom dying would invade her mind and would not leave. Her anxiety began to get so intense that she was starting to question whether she could go to school. I know it's weird and doesn't make sense, she shared. It didn't used to be this bad, but it's been getting harder to deal with over the past few months or so. It used to only happen a couple of times a week, but now it's every day, and I'm being late for school and my teachers want to write me up. So the obsessions here are the thought that her mom will die in a certain conditions. One of them is that if she plays the music at the volume of 7 or 13, mom will die, and that she used compulsive behaviors to calm herself down. These behaviors include that she attempt to not play music at a volume of either 7 or 13, and she also turned on the lights 3 times whenever she entered a room at her house. Another compulsion she has is that she takes large steps when entering rooms to avoid stepping on the crack or space between the door and the next room. Jeanette actually has some good insight because she shared that she knows it is weird and it doesn't make sense. Did you notice anything different? When it comes to the treatment for OCD, exposure and response prevention therapy, or simply ERP, is the first line treatment. It is somewhat similar to exposure therapy. They begin with the situations that can evoke low anxiety, and then they gradually move up to higher levels of anxiety provoking stimuli. In order to use ERP, you would need to be specialized in using ERP and get a certification. Medications, including SSRIs, are sometimes used among people who suffer from OCD. If you're interested in seeing what exposure therapy look like, you can pause the video for now and then use the link at the bottom of this PowerPoint slide and to see an in vivo video. People with body dysmorphic disorder are highly sensitive to the quote-unquote flaws in their physical appearance that are usually not noticeable by others. As a response, they perform compulsive behaviors such as constantly checking in the mirror or always try to hide their physical imperfection. They may pick their skin depending on what the flaw is, because it could be a skin issue. They even ask people around to make sure that they have that flaw. So some examples of the flaws are like a nose. Maybe it's the shape of nose, maybe it's the location of the nose. Wrinkles is another example, and some other skin issues. Many people are obsessed with the hair, especially like thin hair or baldness, the appearance of the vein through skin. Breast size is another thing that's very commonly seen. And for men, it's usually the size of a muscle and their tone of voice. This anxiety as well as the repetitive behaviors cause clinically significant distress or impairment to this person's normal functioning. And the concern of their appearance are usually not the same as the concerns with the weight and their body fat. As usual, you can use the insight specifier to specify if they have good or fair insight, poor insight, or no insight at all. And if someone is obsessed with their muscle size, you can consider putting the with muscle dysmorphia specifier. At the bottom left on this slide, you can see an example of the body dysmorphic disorder coding. Like many other mental disorders, the cause is unknown, but there are certain risk factors that you may want to take into consideration. The first one is family history. If clients' blood relatives have either body dysmorphic disorder or OCD disorder, then themselves has a higher likelihood to develop body dysmorphic disorder as well. And the second thing is not very surprising, trauma, especially with childhood experience, right? Be teased at school based on the way they look. And then personality traits such as being a perfectionism is also something very common among the clients who suffer from all the disorders listed in this chapter. This disorder can also comorbid, which means that happened at the same time with other disorders such as anxiety and depression. When it comes to treatment, again, I would highly recommend you to get some training before you treat people who suffer from this specific disorder. But basically, most of the treatment are based on CBT, such as the actual CBT and ERP and ACT, as well as group therapy, because group therapy can always provide some support from their peers. People with hoarding disorder have extreme difficulty to let things go. They have the constant need to wanting to keep the items as the way they are, and it will cause them great distress if throwing them away. Because of this hoarding habit, their living space is usually very cluttered, and many places have lost its function. This behavior has caused clinically significant distress and impairment in the individual's life. Even if they are okay with themselves, people who live with them are usually bothered by this hoarding behavior, so there may be some conflicts within the home of the individual. Their neighbors may also complain to them, which also cause some stress to the individuals. And then we also want to make sure the symptoms are not due to another medical condition and is not better explained by any other mental disorders. The specifier here include with excessive acquisition, meaning that in addition to the difficulty of letting things go, individuals also actively collecting things back. And those things are usually perceived as um, not have a very high value. They're usually like free items or the items left by others. And of course, you can also use the insight specifier. Hoarding usually starts around ages 11 to 15, and it gets worse with the age. Not surprisingly, hoarding is more common in older adults than younger adults. Some other risk factors include an indecisiveness of their personality. It can be a learned behavior from a family member, especially like a parent. Many people develop hoarding disorder as a coping strategy to their stressful life events. Like people who have lost a loved one, they usually have trouble letting things go. I have a client who's in his 20s and he has hoarding problem. After talking with him, we found out that the root of his hoarding behavior comes from his childhood experience. It turned out that his mom is a bit controlling and she always liked to clean things up. Oftentimes, he will realize that he has lost some important things, such as a painting or some other things that, as a child, we all know we collect some things that don't make sense to our parents, right? So his mom just throw those things away. And so right now he's just really scared of letting things go. And he's constantly trying to save things, trying to keep things, because otherwise somehow those things will be taken away. Does that make sense? Do you know anyone in your life who may have hoarding behaviors? People who have the following characteristics or behaviors are indicative of hoarding behaviors. Those who are indecisive about things, they're constantly losing important things. They are attached to the possessions or some items to the point where they just associate the items as part of their identity. They like to buy things just because they're a bargain, regardless of their actual use. They usually don't invite any family or friends into their home space because it's probably very cluttered. They also refuse people to help with home improvements and home repairs for the fear of losing items. So, what makes getting rid of clutter so difficult for this population? Well, first of all, they may have so many items that it's really difficult to organize. And again, they are so attached to the items, so they just can't let it go. If they do let things go, they almost like they have to go through a grief, which is really painful. And then they usually have this such a great feeling whenever they are obtaining some new items. So that's a reward for themselves. And then, of course, when they get rid of items, they have an intense negative feeling. They are usually very convinced that the items are of great value and it's going to be useful someday. It may not be right now, but it's going to be useful. And then they feel like they're responsible for items. They may think that they have feelings, such as the toys in Toy Story movie. When it comes to treatment, one sad thing is that few of them ever seek treatment for hoarding. This problem is usually discovered when they come to counseling for other issues, such as a grief issue. Therefore, the first thing we want to accomplish here is to somehow enhance their motivation seeking help. Um, so, motivational interviewing can be a really good way to achieve that purpose. Other treatments could include CBT and ERP. We need to be fully aware that this population has lots of shame and they may feel humiliated to share about their real life. Trichotillomania has 5 criteria. Criteria A requires the behavior of recurrent pulling out of one's hair, resulting in significant hair loss. Criterion B require repeated attempts to kind of stop this behavior. And criterion C requires clinically significant distress caused by this behavior. And criterion D and E requires we differentiate between this condition with other medical condition and another mental disorder. Hair pulling can actually occur from any body region. It could be the scalp, but it could also be eyebrows. Actually, eyelids are the most common because they're usually not very noticeable by people. And they may switch between hair pulling areas so that it's less noticeable. As far as gender-wise, women are 10 times more likely than men, but there's no difference between girls and boys. The behavior can occur at any time, but the most common times are during downtime when people are bored, they don't have anything to do. This disorder is often comorbid with depressive disorders and other OCD-related disorders. People are likely to hide this behavior from their friends and family for years. Because of a long history of hair pulling, and there may be some other factors, it's usually a bit of a challenge for counselors to engage this person in therapy. When it comes to treatment, the therapeutic relationship is a key component here because remember, this population has a huge embarrassment associated with this behavior, and they may be hiding this behavior for years. To decrease their resistance, we could use psychoeducation on the behavior or on the disorder, and we can use motivational interviewing to improve their motivation to change. Another helpful modality is habit reversal training based on the foundation of behavioral therapy. Individuals are trained to monitor themselves, to identify the triggers to these behaviors, and then they develop an alternative behavior when when the triggers happen. But this population needs lots of social support, and because there's a high rate of relapse, relapse prevention is also important. All right, the last disorder we're going to talk about in this lecture is L98.1 excoriation disorder. The L codes in ICD-10 stands for skin and subcutaneous tissue conditions. This disorder also has 5 different criteria. People who suffer from excoriation disorder have the recurrent behavior of skin picking, resulting in injury or lesions in their skin. And they also tried repeatedly to stop the behavior, but they failed. This behavior has caused significant clinically significant distress and impairment in clients' daily functioning. And the symptoms are not due to the substance use or another medical condition or any other mental disorder. Similar to trichotillomania, this disorder also begins in adolescence. It usually started as an effort to manage their acne. Then they just keep doing it to the point that they can't stop. As far as the treatment for this condition, unfortunately, there's still a lack of research has been done. The first step for clinicians is usually to figure out what is the function of this skin picking. Does this individual have certain stress or anxiety that whenever they experience the anxiety, they pick their skin? If so, how can we stop that anxiety? What is the root to that anxiety? Similar to the treatment for trichotillomania, HRT can also be applied to excoriation disorder. Other clinicians have also been using mindfulness and DBT. At this point, you have reached the end for this lecture. I hope you found these information helpful. As usual, if you have any questions, please don't hesitate to reach out to me, and I am more than happy to have a dialogue with you and we can discuss various disorders or any confusions that you might have. I hope you enjoy the rest of the day, and I'll see you next week.